Hello, everybody, and welcome to the RCSI Cardiovascular Society Semester 1 ECG tutorial. Tonight, we hope to take you through some of the basics to making reading and interpreting ECGs easy, simple, and painless, and do a couple of examples so that you can apply these skills to some common ECGs that you may see, so that you can familiarize yourself with the systematic methodology to reading and interpreting ECGs wherever you come across them. So without further ado, thank you for coming tonight, and let's get started. So just a quick review of our anatomy and the conduction pathway. So we have two types of cells in the heart. We have our cardiac myocytes and our pacemaker cells. So our SA and AV node are our two pacemaker cells. These are the cells that have that automaticity that kind of keeps your heart rate consistent and going. So we're always going to start at the SA node. Your depolarization, your electrical depolarization, is going to permeate through the atria, and that's going to cause uniform depolarization between the left and the right atrium, so that those two chambers contract together in sync with each other. And as you're moving down, the electrical conductance is going to hit the AV node and kind of travel down through the bundle of His. And just as a reminder, you have your atrioventricular valves, the tricuspid and mitral valves, that are actually acting as electrical insulators, so that the only pathway for electrical conductance to travel through is through the AV node and the bundle of His into the interventricular septum and down into the ventricle. So that's kind of creating a one-way path into the lower chambers of the heart. As you're exiting the bundle of His, you're going to hit the left and the right bundle branches, and then we're going to perfuse down into the Purkinje fibers, which are going to allow for the depolarization of the ventricular myocytes, and that's going to cause, again, synchronous contraction from the lower chambers of the heart. And that's just to keep in mind as we're looking through some ECGs today, that our conduction pathway and the electrical conductance is what we're actually looking at and discussing when we're looking at our ECG tracings. Other thing to keep in mind is our blood supply to the heart, which we know is very important, and this will particularly come into play if we're talking about myocardial infarction. But just so that you, again, have a refresher on what vessels are supplying the heart itself with muscles, of course, or the heart itself with blood, the heart muscle with blood, rather. So you of course, have your right coronary artery and your left coronary artery as your starting point, coming off of the cusps of the aorta, and of the aortic valve specifically. So your LCA is going to divide into your circumflex and your left circumflex and your left anterior descending. The region of the left anterior descending is mostly anterior, and it's going to cover some of the anterior septum, interventricular septum as well. And then your circumflex, your left circumflex artery, and the obtuse marginal, which is a branch off of that, is going to do kind of your lateral portion of your heart, and then it's also going to supply the left atrium kind of inferior or posteriorly and anteriorly as well. So that's kind of your branches off of the left coronary artery. Your right coronary artery is coming down and doing a lot of the anterior portion of the heart. And then you have your acute marginal artery, which is getting into the posterior bit here, and a little bit here you can see in the posterior view. And then the branch off of your other important branch off of your right coronary is the posterior descending, which is mostly posterior, inferior, and you've got also the posterior segment of the interventricular septum being covered there. So keep those arteries in mind, especially when we're talking about myocardial infarction and things that may look like myocardial infarction, but just so that we know kind of what bits of the heart are supplied by what arteries as we're moving forward. So let's get into our ECGs, and hopefully this will make you ready for the words in no time. So we figured we'd start with placement. Now, you have 10 electrodes on your ECG, 4 chest electrodes and their corresponding leads, 6 chest electrodes and their corresponding leads, and 4 limb electrodes and their corresponding leads. So when it comes to placement of these 10 electrodes, there are 2 really important things to keep in mind. That if there's any body hair that you might want to consider removing it when you're placing your leads, you want to make sure that you're getting good contact with the skin so that our ECG tracings and the readings are as accurate as possible. And then you might want to clean the site and sterilize with alcohol, again, just to make sure that there's no debris that's interfering with the electrical signaling. So for our 6 chest leads, the other thing we want to make sure is that our leads are in the right spot, right? Because this is really giving us a picture of what's going on with electrical activity in the heart. So for your 6 leads, here's an example, and you even have a little surface model to go off here. Your V1 through V6 are attached as follows. V1 is in the 4th intercostal space to the right of the sternal edge. V2 is correspondingly the 4th intercostal space on the left sternal edge. I'm going to skip down to V4 because V4 is in the 5th intercostal space, mid-clavicular line, and then for V3 is kind of in between V2 and V4, so like equidistant between those two, kind of creates a diagonal line pattern here, but it should be in between those two. It's still kind of somewhat in the 4th intercostal space, but just in between the sternal edge and the mid-clavicular line. V5 is then in the left anterior axillary line, and it's at the same level as V4, and V6 is then in the mid-axillary line on the left, and again, these are at the same level horizontally, so you kind of create a horizontal line with V4, V5, and V6. And then for your limb leads, they're kind of easy to figure out. You have a right arm lead that should be placed on the ulnar, ideally on the ulnar styloid process of the right arm. You have your left arm lead, which should be on the corresponding ulnar styloid process of the left arm. And then your left leg lead will be on the lateral malleolus of the left leg, and the right leg lead would be on the medial or the lateral malleolus of the right leg. You can do either with your limb leads, and you can see this is would be your example of your right arm lead, and here is a good positioning for your left leg lead, and then you'll have corresponding leads on the other limbs as well. And sometimes you don't actually. That this is the ideal. You don't always get to, if you're in A&E, for instance, you might have to have quick placement, but you do need your limb leads. So you can use this modified Mason-Ligard placement for your right and left limb leads, and you'll just put them kind of on the chest. The right and left arm leads will be below the clavicle, near to the shoulders, and then your right and left leg leads will be in the lower abdomen. But the thing to keep in mind with this modified lead placement is that you want the leads to be equidistant from the lead to the electrode to the heart, and that way you're still getting an accurate reading. But if you don't perhaps have the time to secure or the access to secure all the limb leads. The other thing to keep in mind with our leads is that there's a color coding to them, and we'll give you a quick mnemonic for that. But your right arm lead is going to be your red lead. Your right leg lead is going to be the black lead. Your left arm lead is going to be yellow, and your left leg lead is going to be green. So that is also important to keep in mind when you're going on your leads. So when we're talking about color coding our leads, there are 2 color coding standards. One is the International Electrical Technical Commission, and one is the American Heart Association. And just so you kind of know here is the color coding for both of those systems. We're not going to get too much into this, but just a kind of rule of thumb, or a mnemonic, if you will. If you're using the American Heart Association symptom, you're thinking your left leads are smoke over fire with your black lead above the red, and then the right arm leads is snow over grass, where your right arm lead is the right one, and the right leg lead is the green one. So that's just a little bit on lead placement. So you have the appropriate position, the appropriate conditions, and you're associating the correct leads with the correct colors, and you're applying them accordingly, is also important to keep in mind. Okay, so let's talk about the views of the heart. So we know that we have, or the views of your ECG, you know you have 10 electrodes, but we actually can get 12 views from 10 electrodes, and let me tell you how that works. So your 12 lead ECG printout includes the 6 chest leads that you have, and again, we have 4 limb leads, but in addition to those four leads will give us 6 different views that create, and these 2 separate leads create 2 different planes. So for instance, you get lead 1, 2, and 3, but in addition to that, you have augmented leads, which you might see just on your printout to the right of your leads 1, 2, 3, you'll see AVR, AVL, and AVF. So these are your augmented vector leads to the right, to the left, and towards the foot. And just as an added note, the augmented vectors are kind of a combination of using 2 leads as a negative and 1 as a positive. So these are actually referred to as unipolar leads, whereas your limb leads are bipolar. There's 1 positive end and there's 1 negative end to each of them. And you can kind of see if you're like here the vertical plane with your 6 limb leads is in blue. We will make it in blue. So that's kind of referring to this circle around here in that frontal plane is another name to call it. So you can see going out here kind of towards the left is lead 1, and that is one of your bipolar leads, as is lead 2 coming down here towards the left and lead 3 coming down here towards the right. And then your augmented leads create separate angles where, for instance, in AVF, which is your augmented vector towards the foot, downwards here is actually the positive end of AVF, and the negative pole of it is actually up here between this space that's created by 2 different leads up here. The same thing for AVR, where this is the positive end and the negative end would be opposite it, and then same thing for AVL. And all of this is going to come into play when we are discussing determining access, and also looking at what our leads are telling us. So in these groupings, you'll notice that over here to the left, you have 1 and AVL. So these are kind of, fondly named our lateral leads. They kind of point the positive vectors towards the left and towards the lateral sides of the heart. So that will be important. And we'll talk about the depolarization patterns in just a moment. So that makes a little bit more sense. Whereas leads 2, 3, and AVF, here are our inferior leads. And you can kind of get the sense that these are referring to the inferior portion of the heart here, and that's where you're getting it from when you're looking at that. So this is kind of creating the territories, and I'm sorry, I almost forgot to mention that on the other hand, you have your horizontal plane that's made by your chest leads V1 through V6, and you can see kind of if you were to think of a plane that goes through your chest, then V1, 2, 3, 4, 5, and 6 kind of radiate outwards from there, and that's kind of the readings that you're getting across those chest leads as well. So that's how we're getting our 12 lead view with only 10 electrodes, and this is just giving us some more information about what's going on. We're looking at the heart from different angles, if you will. and it's giving us kind of different perspectives, and this is all kind of encaptured in one ECG printout, which is really nice to have one kind of printout that gives us multiple views or multiple images, if you will, quote unquote images. So you kind of have to think of it in the 3D sense, and that's where or how our ECGs get made, essentially, and how we will interpret them is kind of based off of what we're looking at there. The next thing to talk about is the depolarization patterns, and this is really going to come into play in the next slide, which is a little bit about determining access. So when we're talking about depolarization, right, this is a wave of positive electrical potential that's moving in a unidirectional flow. So if your wave of depolarization is positive ions moving towards a lead, you'll see that come up on your ECG as a positive deflection. So we'll talk about positive and negative deflections when we look at our ECG paper. So just keep in mind, if positive, your lead is always going to be a positive, the positive end of an electrode. So if there's a positive wave moving towards a lead, it comes up as a positive deflection. Similarly, if that positive wave is moving away from a lead, it's going to show up as a negative deflection, and that's what's pictured here and here. And then your other ECGs, or your other electrodes rather, that are kind of along the either perpendicular or kind of tangential to that depolarization propagation, are going to show this kind of biphasic pattern where, depending on where it's located, you might have some upward deflection and then some downward deflection. This is a nice biphasic wave that's showing a equal deflection in the positive and negative direction. And similarly, as you get closer to the direction of the depolarization, you're going to get this kind of more positive deflection than negative. But that's something to keep in mind, because that's going to end up telling us a lot. And in the next section, we're going to talk about our cardiac access, which can sometimes be complicated, but we hope that this will make it pretty simple. So we just talked about the direction of depolarization, but the heart is not just one straight line, right? The way that the heart is kind of constructed, you're going to have depolarizations that are going in all different directions. So when we're talking about axis, we're talking about the mean direction of the wave of a vector. And sorry to get very physicsy on you, but the best way, I think, to think of this is almost like a clock or like a sphere, and the heart is at the center of the sphere. So when we're talking about our axis, we're talking about the summation of vectors of positive depolarization and where that's pointing, or where those depolarization or the sum of those vectors is going. So if you think of, again, this kind of clock or sphere base, you kind of have this 360-degree plane, and your zero reference point would be where lead 1 kind of is, and that's a starting point. And depending on where the sum of the vectors is directed, you're going to have kind of changes in where your axis is pointing and deviating to. So our normal axis is somewhere between -30 and +90, and that's this this green space here, normal QRS axis. And if you think about it, this is kind of pointing mostly towards the left and a little inferiorly, and the way I think about it is, when we're talking about the sum of depolarization, your left ventricle is the larger, more muscular side, so there's more depolarization, there's more positive the vector of depolarization is more prone, or more of that electrical energy is going towards the left to like increase the strength of the contraction of the left ventricle. So that kind of makes sense if you think of your normal axis being kind of to the left and a little bit inferior, and that's kind of what you think about it. So when we have problems, or if we have, hypertrophy in some areas, or if we get some sort of myocardial infarction that causes necrosis, that may change our axis. And you have, for instance, a change that would be, somewhere between 180 and plus 120, which would be an example of right axis deviation, where you maybe have a little bit of right ventricular hypertrophy. So more of those positive deflections are going towards the right, because there's hypertrophy on the right side as opposed to the left. And then conversely, on the opposite side, you have, between minus 90 and minus 30 would be a left axis deviation. ECG basics. So this is our classic standard, nice, clean ECGs. And this is going to get us into our next segment about determination and interpretation. These are the aspects that we're looking at: our P waves, our QRS complexes, ST segment, QT interval, PR interval. All are kind of the important bits of it. And just like we're showing you here, each of these deflections, which are, aspects of electrical activity, are corresponding to mechanical events. So your P wave is going to, show atrial depolarization, and that's always going to be the first part of your ECG tracing that you kind of get a sense of and you're looking at. The PR interval is the duration of time from the start of atrial depolarization, so from the start of the P wave up until the start of ventricular depolarization, which will be your Q wave, which is the first negative deflection of your QRS complex. And what we want to note is that the normal PR interval is less than 200 milliseconds, and we'll get into that when we look at the tracing in just a minute. Less than 200 milliseconds, and that's kind of showing that there's a normal conductance from the SA node into the AV node, and a normal delay of passage of electrical activity into the AV node and down the bundle of His before we hit the ventricles. Which brings us to our QRS complex, which symbolizes our ventricular depolarization, which is going to allow for our ventricular contraction. The normal duration there is 120 or less than 120 milliseconds, and I think that's the easiest part. It's just here in red. The easiest part for us to realize or to notice is really that nice tall peaked QRS complex. And equally important but often missed is the J point, which is just this area here. And the importance of the J point really is when you have this QRS deflection, you want to come up to, there's an axis here of just like normal isoelectrical activity, as you can see the line being drawn there, that goes across the entire ECG tracing. So the J point is just the point where you meet the isoelectric line, and it starts the ST segment, which is our isoelectric segment of the ECG. And this is kind of aligned with, if you think of your ion conductance in your cardiac myocytes, like this is that plateau phase that happens, that prolongs your refractory period where, calcium and potassium are balanced in efflux as repolarization starts to occur. Your T wave is the rapid phase of ventricular repolarization. And then the other important thing to keep in mind is your QT interval, which is kind of your electrical proxy for systole. It is the period of time between your beginning of your QRS complex, which is, of course, ventricular depolarization, and the end of repolarization. So that is indicative of mechanical contraction. And just as a note, that you have a corrected QT interval, so you're looking at 440 milliseconds in females, 460 milliseconds in males, and that's important to look at, because if that is prolonged or shortened, you're talking about lengthened duration or shortened duration of your period of systole. So you see something like this. This is kind of your ECG, your standard ECG or whatnot, and you kind of think, what do I do? And you panic and you don't know really where to go with this. So let's break up and dissect the ECG a little bit. The first thing that we want to point out is that there's a top half and the bottom half. You can automatically just kind of cut it down at the bottom and know that this bottom section is what we call your rhythm strip, which is usually a continuous run of your lead 2 of your ECG. And then on the top of that, in this section, you have your chest and your limb leads, which are kind of corresponding again rather to this visual we have of where certain, what part of the heart certain leads are kind of pointing at. And that's kind of another segment of the ECG. So we'll get into it, but your rhythm strip is really good for determining rate and rhythm. And then you'll see a lot of classic signs of certain different pathologies in the upper half of your ECG based on what leads are being pointed out. And this is just further dissecting that upper portion where you're looking at your chest leads and your limb leads. And I just like to point out, again, like we said, there are certain vessels, coronary vessels and blood vessels that supply certain areas of heart muscle. So in V1 and V2, you're looking at mostly septal leads, but that's still your LAD, whereas V3, V4, in addition to V1 and V2 as well, are kind of pointing out anterior leads. So again, that is LAD territory. As we're moving laterally, V5 and 6 are your septal and your diagonal leads, and that is mimicked over here again in lead 1 and AVL. And last but not least, your inferior leads, which are your RCA predominantly, is going to be covered by lead 2, lead 3, and AVF. So those are just the portions to kind of look at in a snapshot when you're thinking about, I'm looking at, is there something going on with the LAD, whether it's infarction or ischemia or something else. You might then just zoom in on V1 through V4, or if you start to see something that's happening in V5, V6, lead 1, AVL, you're thinking more lateral, and the same thing for inferior. So that hopefully will help to streamline kind of how you dissect up your ECG. You're looking at this again, and you want to start somewhere, so we're going to start to dive into the 6-step method. But before we do so, I'm zooming in really, really, really close here to kind of give you the idea of what this entire ECG kind of is looking like. So on the horizontal axis, you have time. And this entire printout is going to always be 10 seconds of time, and that's going to help us a lot with determining rate when we come to it. And then on your vertical axis, this is actually voltage, but we measure it in millimeters. Each small square we'll get into is 1 millimeter, and that's kind of enough to determine our voltage there. So in your ECG, you have small squares like this, and then you have large squares kind of like this. And what to keep in mind is the rate. So your ECG paper kind of moves at a rate of 25 millimeters per second. So that also comes into play, and you want to make sure that you're paying attention to that. So given this speed, one small square is equal to 0.04 seconds. And within a large square, there are 5 of those. So one large square is 5 times this, which is 0.2 seconds. And if you are converting to milliseconds, like this is the same thing as saying 40 milliseconds, and this is the same thing as saying 200 milliseconds. So hopefully that helps determine a little bit about our time. So doing the math, if you will, 5 of these large boxes equals 1 second of time. And this is really going to be helpful when we're determining rate in just a little bit. And then what is our amplitude good for? So again, right, this is a 1 millimeter by 1 millimeter box. So when you're talking about the vertical axis, I'll actually draw it over here. We're talking about the vertical axis, right? We're looking at the amplitude or the voltage of the tracing. And as you can see, obviously there's peaks and troughs in your ECG, and those are all related to voltages or millivolts, and we'll talk a little bit about what is normal in your voltages as we get into looking at some ECG tracings. So what is the crux of this? What do we use to determine ECGs? Well, we're using the 6-step method, which is just a easy systematic way of keeping on top of reading your ECG, so whatever shows up there, you're always using this method to kind of determine what's going on. And your 6 steps are rate, rhythm, P waves, QRS complexes, PR interval, and ST segment. And we're going to just get into how to use each of those 6 steps in determining what's going on with your ECGs. So step 1, rate. Now, we talked about this idea that your ECG paper is moving at a speed of 25 millimeters per second. So, like we said, one small box, 40 milliseconds or 0.04 seconds. And because of that, we can use the mathematical method to kind of determine rate by a shorthand. So the 300 method is a really good, easy way for you to kind of determine your EC, or your rate rather. So you take 300 and then you just divide it by the number of large squares between RR intervals. And this is just like something to keep in mind as you're going. If there's one large box, right, this is one large box here, between 2 RR intervals, that's a rate of 300. 2 would be 150, 3 would be 100, and that's kind of going based off of the math of how many seconds is passing as the ECG moves along. But that allows us to use this 300-second method to determine what the rate is between our QRS complexes, or the R peaks of our QRS complexes. Sometimes you might be dealing with a very fast rhythm that's happening even faster. I mean, 300 beats per minute is actually pretty fast, but the 150, there's another method that's just a stretch on the 300 method, and you can just take 1500 and divide it by the number of small squares. You're going to end up kind of getting the same patterns there, but just if you have a pretty fast rhythm and you'd rather be precise with counting the smaller squares, that's another method that you can use. But the caveat is that you can only use this method if you have a regular rhythm. So for instance, here we're looking at an R peak here, and then we have another one here. Now, if we count the number of boxes, 1, 2, 3, 4, and this is kind of almost halfway between the 4th and the 5th box. So you can kind of say, okay, we have 300, and then we had 4 and maybe and a quarter boxes or something like that, 4.25, and that's just giving you a little bit more of exact math, but that would give you about 70 beats per minute in your rhythm there. And that's a pretty good estimate, since this is a regular rhythm. Now, if you were to count the number of small boxes here, I've already done it for you, so I'm not going to count them up. There's actually 22, so you can do 1500 divided by 22, and that's giving you 68 beats per minute. And that is, a pretty close estimate for determining that. The other way to determine this is by using the 10-second method. Now, like I said before, each ECG printout is 10 seconds long. So for the 10-second method, if you count the number of peaks, the number of R peaks across the entire tracing, you'll be able to determine the 10-second method. And I'll just go back down to this and use the rhythm strip at the bottom to figure this out. So for instance, in this one, we have how many R peaks? This is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, right? So 13 R peaks in 10 seconds. So if we're using the 10-second method, you're looking for a number in beats per minute, right? So if this is 10 seconds, how do we get to a minute? You multiply by 6. So we have our number of R peaks, 13. We multiply that by 6, and that should give us our a little bit of a closer estimate of what our rate is. And that's 78 beats per minute. So you can use either one. The beauty of the 10-second method is that it is good for regular and irregular rhythms, whereas since the 300 method is really a approximation, you can only use it with regular rhythms, and it's not good if your rhythm is irregular. And again, your rhythm strip is going to that continuous counting lead that you can use to determine what the rate of your ECG is. Now, rhythm. So basically what we want to point out to you here is that there's regular rhythms and there's irregular rhythms. So what you want to figure out is how to determine whether your rhythm is regular or irregular. So how do you do that, right? If your rhythm is regular, it means that the QRS complexes are occurring at the same time along the tracing. You'll find the trick if you have a physical printout of an ECG, if you just get a blank piece of paper and you mark like 3 QRS complexes and you just move from one complex to another, that is kind of a good way to determine if your rhythm is regular, and that's never gonna fail you. And I'll just kind of show you here, right, is the distance between this and this the same as the distance between the next peaks? And you can see it's pretty close, but we'll see on some practice ECGs that you're gonna kind of either get that consistently, and that's how you know that the rhythm is regular, or if it's inconsistent, or it's kind of feels random, then you're dealing with an irregular rhythm, and that's also going to help you determine which of the rate methods to use. Next thing to do is P waves, and this is just giving you some examples of what your P waves might look like, and of course, again, in different leads, we kind of have different morphologies for P waves. So there's a couple of check boxes we want to hit with our P waves. Are they present? So you're looking for, a bump, a positive deflection like this, kind of going across your ECG tracing. And then the other thing to look at is the duration. Is it less than 3 small squares, which would be, about 1.2 seconds. So that's kind of the normal duration for a P wave. So after you notice if they're present, you want to look to see that they're less than 3 small squares. The next thing you want to kind of look at is how smooth they are. So a nice smooth biphasic P wave nice smooth P wave like this just means that the depolarization of the left and the right atria are happening kind of uniformly. Sometimes you'll see something that draws like this is your left atrial depolarization, or your right atrial depolarization, and this is your left atrial depolarization. And then if they're happening kind of like this, in tune with each other, that makes your nice, smooth morphology. Now, depending on where your leads are, you might see biphasic P waves, for instance, in V1, and that just has to do with how the lead in V1 is placed and what it's reading from the depolarizing activity in the atria. And then you can also kind of have more pathology with that. If you have left atrial enlargement, you might see kind of a bigger wave that kind of leans more towards one side than the other. So it's just the next thing to look at is what the morphology is like, and that's going to give you clues as to what's going on. Next thing is your axis, right, is your P wave upright in leads 1 and 2, which indicates that that's the positive depolarization going towards those positive leads and those positive electrodes. And then you usually will see it inverted in AVR. Again, AVR is kind of pointing, looking at it from the right side, so that's positive depolarization moving away from that electrode, and that's going to be a inverted P wave in AVR. And then your amplitude, again, we talked about that, is normally in your limb leads just less than 2.5 millimeters, and then you have 1.5 millimeters in precordial leads, and that's going to come into play as well. Next thing to do is look at your QRS complexes. Again, depending on pathology, depending on the leads, your QRS morphology is all going to be different, and here's just some examples of what you may see in your QRS complexes. But just keeping it simple, you want to say, what does your QRS look like? What's the morphology? Is it narrow or is it wide? A nice narrow QRS complex looks something like this, and the duration that you're looking for is 120 milliseconds or 0.12 seconds, and that's less than 3 small boxes as well. You can see this duration of the QRS complex is literally, it's about 1.5, so that would be normal. A wide QRS complex is going to look wide, and then you're going to get it a lot larger, or larger than 3 small boxes, so that's going to tell you that it's greater than that 0.12 seconds. And then the other thing to look at is the relationship between your P wave and your QRS complex. So if you have a QRS complex, is there a P wave that happens before it? And for every QRS complex, you should be looking to see if there's a P wave before it. You can do it vice versa as well. After every P wave, is there a QRS complex? And again, that relationship is telling you that there is unidirectional movement from the upper chambers into the lower chambers. Next thing is your PR interval. So what is a normal PR interval? Well, it's somewhere between 120 milliseconds and 200 milliseconds, but what we're looking for is less than 5 small boxes. This is the duration from the beginning of the P wave to, again, that first negative deflection of your QRS interval, and that's your PR interval. If you have an interval that is greater than 200 milliseconds, it might be an indication of heart block. For instance, first degree heart block. It could also be indicative of second degree heart block or complete heart block. And so that's something to keep in mind when you're looking across your ECG for at your PR interval. Next is your ST segment. Your ST segment is it begins the isoelectric portion. So after your downward S deflection, you're looking for this nice flat isoelectric segment after the J point, and your ST segment is from the beginning of the S wave to the beginning of the T wave. And this is the early phase of the initial phase of ventricular repolarization. So any abnormalities may indicate, myocardial infarction. You might see, if you see your ST segment jumping up here before your T wave, this is what we call ST elevation. It can also stay low and stay down here before the T wave, and that's ST depression. Elevation is just an indicator of transmural infarct in a part of your heart muscle, and this is where you're looking at your leads is really going to come into play. Whereas depression is it's not complete transmural infarct. It might just be just the outer layer of the heart that has some ischemic injury. So that is kind of differentiating between your elevation and your depression. And here's just an example here for you looking at ST elevation, and depending on where you see it, this is what ST elevation looks like. For instance, here. Putting it all together, let's take those 6 steps and just see what we can determine. Always remember, you'll have a vignette or you'll have a story to kind of lead your clinical acumen. But for instance, this is a 53-year-old male presenting to the ED with an episode of collapse. Now, not a lot to go over in your history, but what are we going to do first in our 6 steps? We're going to look at the rate. So I'm going to start by seeing if this rate is regular by just marking 3 dots on our R peaks there, and then just moving it along to see if they're lining up. So I'm looking and I'm seeing that they line up. They line up all right. They're not perfect, but I'm inclined to say that this is a regular rhythm. So I know I can use the 300 method. I could also use the 10-second method to utilize this. So we're going to look for an R peak like this one that's as close as possible to the line of a big box, and then we're just going to count our big boxes. 1, 2, 3, and this is somewhere between 3 and 4, but if we call it 4, then we're looking at a rate that is I know it's like between 3 and 4, but let's just call it 4. 300 divided by 4. And that's going to give us a rate of about 75. It's definitely more than 75 because it's kind of between 3 and 4, so somewhere between 100 and 75 beats per minute. And if we count the 10-second method, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, that's PVC, 13. And remember, the 10-second method is the number of peaks, 13 times 6, and then you end up with 78 beats per minute, which is fine for our rate. We said our rhythm is normal, and we usually say normal sinus or sinus rhythm. Next thing, we're going to look for P waves, and I'm still looking down here at the rhythm strip, but like, yep, I see a P wave there, I see one there, I see one there. So this is looking to me like P waves are present, and they're also all followed by QRS complexes, which is also super helpful. So we have present P waves, they are followed by QRS complexes, and then let's look at the morphology of our QRS complex. And remember, we're looking less than 3 small boxes. It's a little hard to see, but you can imagine like this is probably about 2 small boxes. So that fits less than 3 small boxes, which would give us normal, narrow, complex QRS intervals. And then the next thing we want to see is I'm using the rhythm strip for all of these just because it keeps it nice and simple. Our PR interval. Now remember, PR interval is the beginning of the P wave to the first deflection of the QRS complex. This one's a little better, but how many boxes is this? Well, the normal is less than 5, so this is kind of 1, 2, 3, 4, 5, 6 probably. So that is longer than we normally like it to be. So we have a prolonged PR interval, and then we said it was probably 6 small boxes. Remember, each box is 0.04 seconds, so you can then determine that the PR interval is 0.24 seconds there, or 240 milliseconds, which is longer than we're looking for in a normal PR interval. And last but not least, we're checking out our ST segment. Now, this is where you might want to venture out away from your rhythm strip to see if you see any evidence of elevation or depression across. Again, if we're looking kind of in I like to start with the chest leads, you might be able to see in this section here that there's something going on, right? And this might be some ST elevation there in leads 1, 2, and a little bit there in lead 3. If you're kind of looking over, you might also see that this is kind of subtle, but there's elevation there as well in lead 1. So you have some elevation in V1 through V3, and some in lead 1 as well. And then like we talked about having the opposite in your reverse leads, this is kind of your reciprocal depression in V5 and V6, so you can put that in as a finding as well. And then in our next example, we're looking at a 26-year-old female who presents to A&E with presyncope and reports feeling lightheaded and dizzy periodically for the better part of 1 week. You know, she has a BP of 110/65. Her rest rate is 16. Her stats are 90 on room air. So what are we looking at? Again, use the 6-step method: rate, rhythm, P wave, QRS, PR interval, ST segment. So what is the rate here? Let's use the 10-second method from the jump here and just count how many R peaks we have. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And we're going to multiply that by 6 for our rate. We have 12 R peaks. We're going to multiply that by 6. And that's going to give us about 72 beats per minute, which I'm happy with. What is our rhythm like? I probably should have started with rhythm, but we do have some tick marks. So let's see if they're lining up across. And you can see, yeah, they're lining up kind of nicely. This is a kind of a large gap, but if you go to the next segment, you can see that they're lining up. So this is, you can say, a sinus rhythm. Ooh. P waves, are they present? And we're looking to see, yes, this is a P wave, yes, that's a P wave, yes, that's a P wave, yes, that's a P wave. And you're seeing these ones are all followed by QRS complexes, so we are happy with that. This is a P wave as well, but you're seeing that there's no QRS behind it, and you might see the same pattern happening again here with no QRS. So that's a clue as to what we're looking at. So we do have P waves, but not all of them are followed by QRS complex, but keep that in mind. Our QRS complexes, though, are nice and narrow complexes. This is probably 1.5 squares there, so less than the 3 small boxes, which means that we're looking at less than 120 milliseconds there in our QRS complex. What is our PR interval? Now, this is where the story starts to get a little bit interesting. PR interval, you're looking at this first one and you're saying, okay, this is where I'm looking. That's the beginning of your P wave. This is your QRS. How many boxes is this? 1, 2, 3, 4. That one's fine. You look at the next one again. 1, 2, 3, 4, 5, 6. Okay, that's getting a little bit longer. You're looking at your next one again. 1, 2, 3, 4, 5, 6, 7, 8. And you're getting a little bit longer and longer each time. This one, 1, 2, 3, 4, 5, 6, 7, 8, 9. And then this one is the interesting one where there's a P wave and then you have no QRS complex. But then you have kind of a reset and you're going back, okay, is this one normal? 1, 2, 3, 4, 5. That one is okay. So we actually have a prolonged PR interval. Oops, sorry. With a dropped beat. And that's what this is showing you here. This is a P wave with a dropped beat. And then last but not least, we are looking at our ST segment and just looking kind of more globally. You're looking for the S wave, and then you're seeing this is coming back to the J point in V1. It's similarly doing it in V3. V4, 5, and 6 seem to hit that isoelectric point, and same thing in your limb leads. So you actually have a normal ST segment. And then what we have, sorry, my handwriting's horrible. What we have here is actually a second degree AV block. And then it's type 1 or Mobitz 1. Wenckebach. So that's just a little bit of practice on how to utilize these moving forward. We are going to break you out into breakout sessions where we will get you practicing your ECG technique, your 6-step method, and kind of determining some ECGs. So good luck.